Our final speaker this afternoon will be Dr. Jonathan Katz. Dr. Katz, that's your signal to start moving towards the front of the room. I can only talk to him like that because I've known him for quite a while. Dr. Katz is the director of the neuromuscular program at California Pacific Medical Center. He has written extensively in the field of peripheral neuropathy and has published key articles on CIDP, multifocal motor neuropathy, DADS neuropathy, and others. He has been intimately involved in devising the diagnostic criteria for several of the immune disorders of nerve. Dr. Katz is an expert in EMG and clinical diagnosis and runs one of the busiest neuropathy clinics in the Bay Area. Dr. Katz has a wide experience as physician, clinical researcher, and patient advocate in neuropathy. He has consulted for manufacturers, infusion centers, and Medicare in establishing standards for the use of IVIG, and he has devised the usage criteria for the state of California. He has also advised Blue Cross on matters regarding appropriate use of IVIG, the diagnosis of neuropathy, and issues around neuropathy management. The key here is his overall goal in the field is to ensure that patients who need medications for neuropathy are able to receive it while gaining a better understanding of exactly which patients are likely to respond. And with that, here's Dr. Katz.
That was a heck of an introduction. Dominic told me I would have to stall while he's getting my talk up here, but the introduction took so long that there was no need to stall. I had the whole stalling thing set up, and I was going to complain, actually, while he was setting up the thing. Here's my complaint. One of the main reasons people get neuropathy is that they get metabolic syndrome. Does anybody know what metabolic syndrome is? So metabolic syndrome is basically the kind of disease people get from getting fat and being unhealthy, and it causes all the same problems we hear about, heart disease, high cholesterol, all those bad things. There's a lot of the story about the basic numb feet neuropathy is moving in that same direction, that's another disease that's associated with all those risk factors. So Dominic, who I love, who I think is one of the great people in this field, invites me here, and then I witness that he's serving cupcakes at lunch, and not only cupcakes, but one of the greatest masses of cupcakes I've ever seen in my entire life. So next year for the food, next time you invite me, I don't want to see that again. All right, here we go. So anyway, yeah, I did. All I'm seeing today is cake everywhere. It's wrong. It's wrong. So anyway, we move swiftly to, of course, I'm just being funny, sort of. So anyway, we move quickly to multifocal motor neuropathy. Does anybody in this room have multifocal motor neuropathy? So we have one person, sort of, two. So multifocal motor neuropathy is, and you'll see this, it's the rarest of the rare diseases. So I get to talk about a disease that one person in all of the two people in all of California have, which is fantastic. So I'll try to make this interesting for you, and I'll get off topic a little bit, and feel free to cut me off, ask questions, ask weird questions, ask about donuts or cupcakes or cake, whatever you want. So, oh, okay, there's a question. How's that? All right, so multifocal motor neuropathy, what is it? So it's an autoimmune disease, just like you've been hearing all day, but it's only in the motor nerves. So it only makes you weak. It doesn't cause any sensory loss. As Dominic hinted at, the scary thing about this disease is it looks a little bit like Lou Gehrig's disease. And Lou Gehrig's disease is the much more common of the two diseases. Lou Gehrig's disease is terrible. Multifocal motor neuropathy, treatable. So there's a very small percentage of patients who have this clinical presentation, who have the much, much better diagnosis, but they're mixed up with this other hard to separate from it disease. So a lot of patients, not surprisingly, are going to stumble into a very scary world for a little while until somebody sorts out that it's actually the more benign disease. Actually, what happens in practice is Lou Gehrig's disease is such a bad thing to tell people that the doctors, probably to a degree out of the kindness of their heart, would rather hope that it's multifocal motor neuropathy. So what you see much more commonly than the story Dominic told you, which is somebody who has multifocal motor neuropathy getting told the sad diagnosis they have Lou Gehrig's disease and freaking them out for a couple of years. Much more common is somebody who's actually got Lou Gehrig's disease getting treated for multifocal motor neuropathy, and after a period of time they find out that they're not responding to therapy, and it gets common. So we'll talk a little bit about that, and I'll try to turn the talk into just the general concept of diagnosis. Multifocal motor neuropathy is almost always a disease of the hands, which the two people in the room, I suspect, both have hand involvement. It affects the legs sometimes, but much less commonly. It's not like a progressive disorder. You'll get like a hand get weak, and then maybe a couple of years later, the other hand gets weak, then maybe a leg gets weak. But it kind of happens in steps as opposed to something that's a progressive disease. And that's a little bit of the clue to how you recognize it. The picture here shows the guy on the left. I do these in all my talks, but the guy on the left has a median nerve picked off. That's shown by his thumb. An ulnar nerve that's weak, maybe a perineal nerve that's weak that causes a foot drop, but no sensory involvement. And that would be a typical picture of this disease. You just lose a lot of nerves. And then we're done with multifocal motor neuropathy. That's really all that you need to know because it's such a rare disease. But we'll now talk a little bit about why I think, this is a talk I actually give to doctors at the American Academy of Neurology every year. And I will get into what I hinted at the beginning. Why is neuropathy diagnosis so hard? What makes this, I think, the hardest diagnostic field pretty much in all of healthcare? And I run a clinic in San Francisco where we see patients from Nevada, Oregon, Washington, sometimes from Southern California. Now Southern California has very good neuromuscular doctors. I would say 3 or 4 years ago that might not have been the case. But we see patients from all over the place, and the reason is because I think this is just a super hard field to figure out what's going on, and there's reasons for it, and we're going to go over a few of them. One of them is the tests are really hard to interpret. So people do nerve conduction studies, and they're trying to decide from like these waveforms, first if it's normal or abnormal, and then if it's abnormal, is the problem on the coding of the nerve, hinting that it could be a disease like CIDP or multifocal motor neuropathy, or in the axon, indicating that it's another kind of neuropathy that might make your feet go numb or fall asleep. It's actually not as easy to do as you would hope. And if you're not somewhat expert in this area, there's a lot of ways to go wrong. Like, is a little abnormality enough to matter? Or if it's a large abnormality, why is that happening? Because the nerves are dropping out or because the myelin's dropping out? This is all very, very hard. I would have very little trust in somebody doing this test and trying to make a diagnosis who doesn't really have a lot of expertise in the area. The other thing, which is hard to understand, and I'll play a little trick on you in a minute, is that we don't have a lot of names for these diseases. Like, you hear all these weird diseases. I heard somebody talking about it earlier as a joke, but they were sitting there going, dads, and like, I'm the person who invented all these words in the first place. And so I know the secret of why we had to invent all those words. And it's because if all you have is CIDP and idiopathic neuropathy, you end up lumping a lot of different things into the same category. And there's no way you can lump things that are clearly different from each other. If you have 3 things and 2 of them are clearly different from each other, but you only have 2 names, and all 3 things are different. Somebody says to you, take those 3 things and put them into the 2 categories, but all 3 things are different. You're going to be sitting there going, how can I do that? That's really, really hard. So this is my joke about neurologists. It's like, you go to a neurologist who's not that smart, right? So and there are a lot of them. But they're not smart in the sense that they don't try hard and study. They're not smart in the sense that they were just taught medicine the wrong way. Like the med schools don't even get this. And the deans of med schools are usually scientists, so they don't get it. So there is this giant gap. But you go to a doctor, and the doctor is actually very smart, but they're actually not that smart too. And you go, maybe two neurologists, let's change the joke. Maybe two neurologists are walking at a zoo or at a farm. And I don't know why they're there, but you have these two neurologists and they're just walking along. And so one neurologist turns to the other and says, is that a dog or a cat, right? And the other neurologist looks up and he sees that. The problem is the neurologist answers the question and says it's a dog. And why does the neurologist do that? Does anybody know? What was the right answer? Right. The right answer was neither, right? It's not a dog or a cat. But neurologists don't know how to do this. So they'll look at a disease that doesn't look like anything that they've ever seen, but try to lump it into something they know. And they don't think just even a little bit out of the box about what they're really doing. And that gets to be a gigantic problem in neuropathy, because I'll show you in a minute why. I hope I have the slide in here, but if I don't, ask me at the end why. But this is kind of the logic. So what we end up doing is we take these conditions that don't look like multifocal motor neuropathy, and they don't look like idiopathic neuropathy, and they don't look like CIDP, and we try not to lump them. And when I was younger and I cared more about writing papers, what I realized what we had to do is start naming disease. So we'd come up with these really weird things. So axonal multifocal motor neuropathy without conduction block or other features of demyelination. This was maybe 9 cases we had seen out of hundreds, but they didn't fit anything. So it becomes very important to name these instead of calling them a dog, because a dog looks more like a cow than a cat does, which is actually quite obvious, right? That it would be, if those were your only choices, you would call that a dog, but it's obviously not the right thing to do. So this disease gets translated also as multifocal multifocal acquired motor axonopathy, which is MAMA, which was kind of our antidote to dads, because we didn't want to just be pandering to one gender. But so this is a condition that sometimes you just have to name things because they're atypical. And this is kind of just something that we present just to kind of amuse people even further about it. But let's say you go to a doctor and there's 2 diagnostic tests they could run. And this is what you're trying to diagnose is when you walk out of your driveway in the morning, you walk out of your house in the morning, you're trying to decide, like, did it rain last night? It's less of a question here in Southern California than Northern California, but you're trying to decide, did it rain last night, or was why? You're trying to make a diagnosis. You can do 2 tests. You could look at your driveway and diagnose it with dry or wet, and you could look at your lawn and diagnose it with dry or wet. And you know that if they're both wet, it rained. And you know that if just the lawn is wet, the sprinklers were on. And you know that if they're both dry, that it was a nice night and nothing happened. And that's what diagnostic testing is. But a lot of the times, the diagnostic testing just doesn't cover all the possibilities. So really geeky neurologists start like recording in their database what they see every single morning. And for like 2 years, everything's fine, but then you walk out one morning and you've got like a giant problem in your hand. And it's really important to address every patient individually, especially when you get into situations that aren't in textbooks. And in neuropathy, there are a lot of situations that aren't in textbooks, and it's just really important for all of you to be able to communicate with your doctors about yourself and not get pigeonholed. So what do you do with a case like that? What would you do? The right thing to do is to think hard. Somebody washed a car before you got up, and that's why your driveway is wet, and the other thing is dry. And the wrong thing to do is to not call it a rainstorm variant, which I think becomes like a really important message, because again, neuropathy presentations can be really, really weird. Another issue that comes up is just understanding, like, all of you guys, not the numb feet, but the ones with, that's a mean trick, but the ones with multiple neuropathy, are actually pretty rare diseases. And I think, we do our best. That little blue sliver, I think, is really getting very close to what the number of patients with all neuropathies, if the whole pie is the number of patients with neuropathies, the ones that are going to have really robust responses is actually a really small percentage. So a lot of this does get to be about communication and understanding whether your therapies work and having conversations or your therapy's worth it. Dominic is an example of the very small sliver of somebody who has a wonderful response to therapy, but none of this stuff is very easy. And then you get into questions of more weird diseases that we've had to write about. So Flail Arm Syndrome, these are people who get this really weird presentation where their arms just start hanging there at the sides. And what happens to them is 10, 15 years can go by and they just lose all the function of their arms. And they have what we call man-in-the-barrel syndrome, and they walk around with severe arm weakness. And this sometimes does turn into Lou Gehrig's disease after a long time, but sometimes it just remains as Flail Arm Syndrome. But I have seen tons of cases of people who get this weird presentation, and the doctors haven't heard of this condition because it's so rare. And what happens to the doctor is they say, this patient doesn't have Lou Gehrig's disease, obviously, because they're not dying. In Lou Gehrig's disease, you die in 2 or 3 years. But the only other disease they could think of is multifocal motor neuropathy, because that's a motor presentation of the arms too. But obviously, that's not multifocal motor neuropathy. It doesn't look anything like what I showed you in that first picture. So a good diagnostician should pause and say, I don't know what I'm looking at. But what happens in these cases is these patients get very frequently treated with IVIG. And do you think they respond to IVIG? They never respond to IVIG because they don't have multifocal motor neuropathy, which is the only disease that responds to IVIG. So you get into this very weird logic where you really need to think hard about what things are called and what they are. And then there's another disease called primary muscular atrophy, and you don't have to really know what this slide says, but the point behind it is, again, there's just a lot of clinical presentations, tons of them. And I'm just talking about things that are asymmetric and only affect motor neurons. I'm already up to 3 that I'm telling you about. I could give you a list of another 5 or 6. Stuff is really, really complicated. And then you get into the sensory presentations and the mixed sensory motor presentations. And then I think we need to just talk for a second, like I like to do when I come down here, about cost issues. Because if you heard my introduction, I've worked for everybody. Like I have to disclose everything. It'd be easy for me to disclose just the groups I haven't worked with, because that would go a lot quicker. But I've worked with Medicare, I've worked with insurance companies, I've worked with infusion companies, I've worked with manufacturing companies, I've worked in my own clinic, I've worked with patient support groups. And I think if you could step back and talk about why, it seems like there's conflict between insurance companies and everybody else, it's really because there's a lot of mistakes being made on both directions. So the insurance companies get their guard up because they see a lot of IVIG being given to people who clearly don't have the disease. And the patients get their guard up because there's always a story about somebody who was misdiagnosed and didn't get therapy for a long time and lost function. I personally think probably there's more mistakes being made on IVIG being given to people who don't need it. And you read in the newspapers, I'm sure you've figured out that healthcare is very expensive and we have a few problems in this country. So there is an element of social responsibility, and I think as I go to the next slide, there's an ecosystem here. Everybody's looking out for themselves, and this happens a lot, I think, in capitalism or in America or whatever, but Dominic will probably kill me for saying that and start calling me a socialist when the talk's over. But, salespeople, are out there. There's the concept of early diagnosis, like let's do it fast, let's not hurt anybody. IVIG is very expensive, and sometimes the other treatment's prednisone. Nobody wants to take prednisone, but it's basically free. So you can see where a conflict's going to start building up. Like an insurance company says, take the cheap medicine, maybe you won't have any side effects, and that would be great. And then the insurance companies try to set up criteria to be fair for everybody, but I just told you this stuff's really complicated. The criteria are just really hard to set up, and make any sense, because how do you even set up criteria when you got 250 different individual clinical presentations? And then you got patient groups. So it's a hard ecosystem to work with. And then this slide just kind of says, like, I'll show you right here, but if you look at the 47.5%, I am not talking about Mitt Romney here. But what this tells you is the percentage of patients with CIDP in a good study that actually respond to IVIG. It's less than 50%. So there's a lot of people getting it who have no response. 22.4% is the percentage of patients who got placebo who responded to therapy. So some of these cases that they're calling CIDP are getting better on their own. So you also have to work through all that stuff. And a lot of cases that get called CIDP are not going to respond to therapy. So you have to work through all that stuff. This stuff is not easy, and you throw the money side in there, and people get into all sorts of discussions that don't make any sense. Last slide I'm going to show you, and then I'll open up for questions, is this is just the basic concept of dosing of IVIG. And it also raises the question, there's very large differences in people who have the same disease and the amount of IVIG they need. So again, criteria and hardcore rules are very hard to work out. The main blessing I would hope for everybody here, and you've heard it many times, for all of these neuropathies, multifocal motor neuropathy, everything, is I think you need a lot of trust in your doctor. You need a good relationship with your doctor, and you need to be kind of brought into the right place when it comes to having the knowledge to understand what it's going to take to get yourself better. But again, so I'm done, but it's just a very, very hard area, and I think it's very manageable in almost every single case. So, you should all be feeling pretty good. The fact that you're here probably is a good sign, and the fact that people like Dominic are trying to bring everybody together and educate is extremely important. I think in the long run, we're going to need literally national structures that are involved with collecting data. I've been talking about this a lot today. Helping doctors get educated, helping patients get educated, but I think there is a ways to go, and that's why I think groups like the NAF, I think, can be very important in solving a lot of these big issues. But anyway, thank you, and I'll open up to questions, and then run to United. Yes?
Two questions. One is fibromyalgia. Is that a type of neuropathy?
So fibromyalgia. No, but if fibromyalgia is just, and the easiest way to remember what fibromyalgia means is just think about the word. Fibromyalgia just means your muscles hurt, and it's a syndrome, and it's really common, and I believe it's real. But fibromyalgia is just a fancy way of saying that your muscles hurt, and a lot of us old people, I'm officially an old person, a younger old person. I'm at the beginning of the old age. I'm an old age infant. But the thing is, your muscles start to hurt, and that's what fibromyalgia is. It's just a fancy way of saying you have muscle pain. And it's real, and it definitely is a whole nother lecture for how to deal with that.
Okay, the other question is clinical studies. Now, I took a couple, and they were real dangerous, didn't work out. But are they okay if you feel like they'll discover something worthwhile? Can you help?
Yeah, so our center is involved with a lot of clinical trials, and the question was, are clinical trials okay? Are they safe? Should you volunteer for them? I mean, absolutely. Volunteerism is very important. We need everybody who can get involved. The main tenet of a clinical trial is informed consent. So it's great to keep your eyes open. It's great to participate. But when you sign up for a clinical trial, the right thing to do, there's these review boards that are looking at the trial and making sure that they're safe. And you have to also feel like it's the right trial for you once you talk to them. And it takes another thing that takes a lot of education, could be a whole lecture on itself. Back and then front. So the question is that you have a neuropathy, you've had back problems too, and you have a drop foot. So, and then the question is, will it go away, and is there good treatment? I mean, that gets into the individualized treatment. I could think of the drop foot sounds like it's from your back. Sometimes those go away, sometimes they don't. There's ways we can kind of predict it if we examine you and look at a couple of tests. So you'd want your doctor to talk to you about that. And then the neuropathy, it could be from the back, it could be from other causes. You have what? Oh, Muggus. Yeah. Yeah, I would put you in the moderately to severely complicated category. Question?
Yes, Doctor, when you first began speaking, you talked about a metabolic syndrome as being a cause of neuropathy and a great cause.
So let's be careful of the word cause. Let's use the word association. If I said cause, you can rewind the tape and tell me I shouldn't have said it. But yeah, there's a strong association between all those things like sugar, cholesterol, belly fat, and neuropathy. They come together. There's a group from Utah that writes a lot about this, and it's very believable, especially for the burning numb feet neuropathy.
Have you ever noticed if you took all those things away from that individual, the fat and the sugars and all this, do you see a reversal in the condition?
There are people who I've seen, it's always hard with neuropathy to know exactly if it's getting better unless you do a trial, but there's a group in Utah, again, a very strong group at the University of Utah that looks at these questions, and they say if you get yourself back into shape, the neuropathy can get better. So that means, that's why this whole education thing about the cupcakes becomes very important, because sugar's looking more and more like the enemy of good, of the good people. Yes?
You say to have a good neurologist that you have faith and trust in. Well, that's really hard to do. How do you know where you've got a neurologist? Is there any guidelines you can give us, things that we should understand from our neurologist?
So basically, you're telling me neurologists are awful. I appreciate that.
Well, I've had some pretty rough years. The one that said, oh, well, I see you're taking thyroid, that's it. You're taking even better doses and your neuropathy is going to go.
I would agree. If this is being taped, I'll get in trouble for saying this, but I think you have a really wide range of skills in neurologists. I mean, everybody who Dominic has invited to this talk, every neurologist that's in this room right now, which I think is down to me and Jeff Ralph, good neurologists. Everybody else, terrible. No, I mean, in all seriousness, there's truly a wide range of neurologists. It's an incredibly hard field. We are not like an eye doctors. They have it easy. They look in an eye. I mean, imagine that. It's an eye. There's nothing. I think I could, seriously, I could do LASIK surgery by Friday if I really set myself to do it. But neurology is a lifetime discipline, and there may be a neurologist who's fantastic at multiple sclerosis and terrible at neuropathy. I think I'm very good at neuropathy and terrible at multiple sclerosis. So it's not one thing, and the field is really hard, and that's all I'll say. But Dominic knows who's good, so talk to him is the answer. Back there. Yeah. Now you're going to go back and talk to her, and you're going to say, Dr. Katz said it's something else. I think 2 Neurontin and you're walking into the walls, it's not the Neurontin. I mean, that's a dangerous thing. And then what I liked about your question too is like the proof that you're not having side effects of medicine is you could drive in an RV from San Carlos to Los Angeles. That's fantastic. Yes.
Have you had any experience with the use of subcutaneous IG versus IVIG?
I mean, so the question was subcutaneous IVIG versus the regular IVIG, right? Subcutaneous IG versus IVIG. I mean, subcutaneous IVIG is looking more and more like a real therapy. For me, and this is totally honest, I still haven't gotten over like the mental thing of injecting myself, right? It's just kind of grosses me out. But I think for any patient that wants to, I think all patients on IVIG should think a little bit about what's preferable to them, and then it's certainly worth a try if you think the subcutaneous way to do it is better. You know, I see no problem with giving that a try as therapy. I just can't get over the mental hump. It seems to me that if it were me, I'd rather have it IV and have a nurse do it than stick needles into my fat and lie there. If at the very worst, it's a reminder that you're fat enough to stick a needle into your fat, which is not good. Yes.
On the drug Neurontin, I was on it for a couple of years, and then I started to have hallucinations while I was driving. Is that a possible side effect to kind of be almost, psychedelic?
So the question is having you guys ask fun questions, because I could just like have a field day with these. Having hallucinations, how much Neurontin were you taking to have these hallucinations? 300 or 400 milligrams of Neurontin and you were hallucinating. Right. I mean, anything is possible. Let's just leave it at that. But if I were your wife, I'd be worried. Seriously. No, that's not a lot of Neurontin to hallucinate. I mean, I would have thought about other causes. It could have been anything. And also, if you're on a medicine for a long time and then a side effect picks up, we generally don't think it's from the medicine. If you're starting a medicine or you increase the dose or you add a drug that interacts with it, then we think about the medicine. But in general, when things come on a long time after you're taking them, especially if you're on a low dose, I wouldn't think that that's the cause. So, you know, you might have been hallucinating for another reason, which is unrelated to the Neurontin. Neurontin's a wonderful drug for neuropathy. It has very few side effects. I have no hesitancy recommending it to somebody. Yes?
I know patients that are using IVIG for RSV or CRPS, and you said that it was only really good for multiple neuropathy or CIDP.
Yeah.
Do you think those patients maybe were misdiagnosed or something, or why is it working for?
So I'm giving a talk on Friday. So the question was IVIG for what? Reflex sympathetic dystrophy, and what was the other one?
Chronic regional pain.
Same thing, so chronic regional pain syndrome. So these are two diseases that are really not diseases, they're syndromes. And I'm giving a talk on Friday at a doctor's meeting we're having in Orange County, which is about where it's basically a talk where somebody blew a fuse in their brain and started doing something really weird, and then everybody else started doing the same thing. And I think IVIG for reflex sympathetic dystrophy is just getting really weird. There's no evidence that that would make sense. And you know, it's just, how do these things start? And how does the word get out? And how do ideas flow through, you know, our culture? So that one is just like completely unevidence-based and frankly a little weird. I mean, Jeff, do you agree with that? He does. If Jeff agrees, then it's definitely, Dr. Ralph knows. Anybody else? Yes? Now that's crazy. So it was so he said, if I had peripheral neuropathy, I'd never take another drink in my life. You see, that's another, like, somebody's logic got twisted. That's like the cat and the dog thing. Okay, here's two things that are true. And then you could tell me why that's not the conclusion. Truth number one, if you drink like a fish for a long time, there's a good chance you get a neuropathy. Okay? So that's true. Number two, some people get neuropathies completely independent of drinking, right? Like hopefully everybody in this room. At least that nobody's going to admit the first cause. So does it follow from those two statements that if you get a neuropathy, you should never drink at all? No, there's absolutely no proof. And it ultimately gets to be a quality of life question. Like that's like a mean thing for a neurologist to do, to say, like don't do what you enjoy because theoretically I'm going to totally twist logic. And that's what neurologists do all the time. That's why they're such awful people. I mean, that is true. Oh, it's even worse. A primary care, that's as bad as it gets. Yes? You know, it's a good question. Why does it happen that people get neuropathy after drinking? One of two reasons. Alcohol is toxic to nerves when you have enough of it, or people who drink enough are lacking certain nutrients that could cause a neuropathy. But nobody really knows which of those two it is for sure, and maybe it's both. But that, yes? No, we would have to blindfold you and walk you in. But if we did that, the Congress, the Republican Congress, would get mad at us for the trade-off, and we'd all end up on Fox News. It would be terrible.
Okay, I think we're good.
One more. Well, there you go. There you go. But so that's a great point, because you have numb feet, so your balance is off, and then you drink and your balance is off. But that's, in my defense, because you caught me there, but in my defense, that's also a very different statement than just don't drink because you have a neuropathy. So, you know, sometimes you just have to think straight. Like Todd Levine said, sometimes like you get a little zapper in your foot and you ask, you know, you get a sting in your foot and you look down, and every once in a while your wife actually is sticking a pin in your foot. And that's just a really weird. All right, well, thank you guys very much.
That's going to conclude our conference today. But before you leave, raise your hand if you learned something today that you didn't know yesterday. Okay, pretty unanimous. So we invite you to come back next year. I'm not sure where we're going to have another conference, but we've enjoyed having you here, and thank you very much for the time. And also for your resilience not to try to get on a freeway at this time of day. So you might want to hang back, have a good time, and hit the freeway about 7. Thank you.